Good morning, everyone, and welcome, and thank you to everyone for coming on this hot day. So I'm Helen, I'm an A&E registrar based at the John Radcliffe Hospital in Oxford, and this is the second in our Emergency Medicine CESR webinar series of 2021. And over the next 5 months, we're going to be covering what's needed in your actual GMC Emergency Medicine CESR application, and we've got lots of experience and expert here today to help us with that. So just a little bit of background about me. I was in training until a couple of years ago when I decided to leave for various reasons, as I'm sure you know everyone's kind of got all their reasons for doing the CESR. And I realised that the CESR pathway wasn't particularly transparent, and there's quite a lot of stuff that you need to do, but it's not always clear exactly how you need to do things. With some of my colleagues, I felt that we could perhaps help this process using the expertise of people around us who've either been through the process or are involved in that process in some way. So this is the second in the series. Hopefully it's going to be useful for people at all stages of their journey. And what we're going to be going through today are sections 11 to 18 of your application. These headings have been lifted directly from the GMC divider pack, which is how you're going to be expected to organise your application. I'm just going to share my screen here actually and show you what we're going to be covering. Let's pop this on. Okay. Oh, hang on. Sorry, technical hitch. Okay. Excellent. Can you see that? Oh. No.
It was there, Helen, but then it disappeared. It disappeared now, but it was there.
Okay, so let's try again. There's it. Okay. So, so we're going to go through from sections 11 to 18. So we've got 360-degree multi-source feedback, awards and discretionary points and letters, personal development plans, participation in assessments, appraisals and appointment process, logbooks, number 16, which is a long list, medical reports and case histories. And this is to complement what we did last time, which was numbers 1 to 10 of the application pack. So come back. Am I still screen sharing or not? No. Okay. So today we've got colleagues of mine from Oxford. So I'm going to hand over to Priya, and she will introduce the rest of the day. Please feel free to put your hand up to ask questions. You can write stuff in the chat. In the chat we have Priya's kindly put up exactly what we're talking about today. So links to the application divider pack, and also I will add up a link to the specialty specific guidance, which is it's sort of what we're talking about today in terms of what you should be adding into each part of your application. Have a great session.
Welcome everyone. I'm Dr. Priyadarshini Marathe. Along with Helen, we are the CESR Aspirant project team at Oxford, and I am delighted to welcome our expert speakers today, Dr. Simon Smith, Dr. Tom Hughes, and Dr. James Ray. Please may I ask each one of you to give us 1 or 2 lines about who you are and what your connection to CESR is. So Simon, do you want to go first?
Yeah, hello, Simon Smith. I'm an A&E consultant in Oxford, and I was a very traditional cowman style trainee. So my connection to CESR is that I'm actually a CESR assessor for the college, and I've been doing that for about 10 years or so. So I sit on the committee, and then sporadically, about 4 or 5 times a year, I will assess somebody's portfolio for the college, and then that gets written into a report, which then gets sent back to the GMC, send it on to the trainee, sorry, the CESR aspirant. That's my role.
Thank you, Simon. Tom?
Hi, good morning. So my name's Tom Hughes. I trained partly in the UK and partly in Australia, and then was a consultant in Australia for 5 years. And so coming back to the UK, then I had to go through the CESR route. It's obviously changed a bit since then, but I think the hoops you have to jump through are probably similar.
Thank you, Tom. James?
Hi everybody, I'm James. I'm a EM. I'm muted again, and I went through multiple career routes. I started off with I went through started my higher surgical training in surgery, and then ended up being a GP for a period of time. Became a GP partner, and during that time worked like many GPs do in sorry, apologies for that, in ED, and which is a common interface, and I did find that my ED working was much more interesting than my primary care work, for me anyway, personally. So I switched ship, and appreciated that CESR route seems much more attractive because of everything I'd done previously, and actually I'll come to it when I speak, but getting acknowledgement of everything you've done is really can be one of the biggest challenges, particularly if it's historical. But eventually I did this route, and I think I was, apart from Tom, I was the next one on the list to go through CESR training in the group successfully, closely followed by Alex. But that's me. Thank you.
Thank you, Tom. Thank you, James. We are going to discuss a lot of topics today, and just because our speakers are quite busy people, and they are trying to juggle this meeting between others, we are going to switch up the order a little bit and ask Tom to go first. And the way we've divided the topics today is Tom is going to start off with telling us a bit about section number 17, correct me if I'm wrong, Helen, section 17, which is case histories. And what we'll do, the way we're going to do this webinar is we will take per section. The expert speaker is going to start off by telling us a little bit about it, 2 to 3 minutes, and then please feel free to ask your own questions from your own journey, from your own GMC application that you're putting together, so then we can talk about it a little bit more. So starting off with Tom, and the first one is case histories.
It's medical report. I mean, it doesn't really matter, but just
so for this, do you, for the medical reports, do you
okay, let's do medical reports. Tom, let's do medical reports, please.
So by medical reports, you're talking about the reports from your supervisors. Is that what you're talking about, or is this because that wasn't in my previous one? Should we do case histories first, and then
okay, all right, let's do case histories.
Okay,
thanks, Tom.
So in terms of case histories, the way I guess this is sort of evolved is that the things that I look for from in terms of understanding a case history, and Simon would want to describe this as the assessment. But what you do in medico-legal reporting is actually quite a good template for thinking about the case histories. And so the way you do it is to put a sort of introduction, and then facts so make sure that the body of the medical case is factually based. So you don't put what you did or justify your what things happened in the sequence of events, and then you parcel up the learning and the insights and what you felt in as the insights that you had from this. And so you've got the documentation that you did, and you've got to make sure that this is suitably anonymized, so you can't trace the patient, you can't trace you, because this information could be shared. So this is part. It's the way that you think about structuring it. You need an introduction, and then just sort of stick to the facts and describe the chronology of the case, and then after that your insights, your feelings, and what you learned from that episode. Simon, have you got from your insights of reading these and assessing them, does that structure work for you when you're trying to assess things?
Yes. So if you look at the SSG, it basically says you've got to put 10 case histories, and these are a bit more like they're like your reflection, but they're reflection plus. So it could include your case notes, and sort of a discussion of why this case is sort of a sentinel case of the 10 you're going to submit, to demonstrate what you've done, the complexity of it, and your high level functioning. So that's kind of what the case history is showing. So yes, you can do the paperwork and you can do the clinical skills and the clinical reasoning properly, but actually sort of an illustration of some of the higher level stuff as well.
And so the one that I've done recently was one I did for the clinical governance meeting, and so I'm happy to share that as an example, heroic or anything, but there's an introduction, and so this was done as a PowerPoint presentation, and then a sort of factual chronology of what happened, and then the sort of insights and facts around that. So I mean, obviously when you're doing this as a report or as a case history, then what I mean, this is as a verb, as a written document. How long should these be?
So they do vary immensely. I think you're looking at, particularly if you include, a copy of your patient notes as well to discuss it, you're looking at 3 or 4 pages long, as a ballpark figure. So, a couple of pages for your notes and the introductory bit, and then sort of a page or so discussing what you did and what this shows. Sort of a reflection, if you like.
Yes, Helen?
Just ask, so I mean, I'm presuming, Simon, that you would expect people to have a broad range of different sorts of cases that they would present, because you've got 10 to demonstrate competence or maturity in different areas. Is that right?
Yeah. So usual wording in the SSG is across the breadth of the curriculum. So a couple of major cases, a PED case, a resus case, and a slightly more complicated ambulatory case, that sort of thing. Yeah.
And just in your experience of someone who assesses these things, what are the sorts of things where people fall down?
Well, the most common thing is not to include them at all. You'd be surprised how many people don't include anything like this. And we'll probably discuss it later on, but they sort of conflate your logbook with your case histories with evidence of you just putting some notes in, basically. So it's not just your clinical records, although they are a useful part of it, because they all demonstrate some of the ancillary stuff, like you can write legibly. But it's the sort of reflection plus bit, which people don't really do very well.
We've got a question, Simon, in the chat, which is someone's asked: is there a template for these case
No,
studies?
you can be as creative as you want with this. But that's the whole point of CESR generically, is you can be creative about your evidence. You're not confined by a curriculum requirement. Yeah.
So the idea is to have 10 case histories. That means take a case that you have seen and has affected you in your training. Try and make them as simple or as complex as possible. Write an essay type reflection on it, and then supplement that case history with extra information. For example, a discharge letter, a letter to a colleague, link it to a curriculum item that you have done a evidence-based learning session on. And then put all of that together and call it case history 1, and then do that 9 more times. Is that what you would like to see when you look at a CESR GMC evidence pack, Simon?
Yes, yeah, absolutely. And what was also useful with all of these sections is to start off with a summary page of what's in your section and what it's showing, and which bit of the curriculum you're trying to demonstrate, or bits of the curriculum you're trying to demonstrate with it. Because that makes it easy for me, because I don't have to plough through, as a professor, plough through lots of stuff. I just look at the front, yeah, so they've covered this. So it helps me organise my thoughts as an assessor. And it's all about making my life easy, obviously.
Yes, this is one of the big advice that you had given me when I was putting together my portfolio, which is make the assessor's life easy for them. Make it easy, organize it so that they understand what evidence you're putting together. So a summary page with bullet points or points of case number 1, this is the case number 2, this is the case. And under each case, all the evidence that you're providing to show the complexity and you're learning from that case. That would help. James, do you want to add anything to case histories?
Yeah, it's funny, I'm just opening up my my own. So I used I use a lot of reflective notes on cases. I actually used my, I don't know whether this is allowed now, but I use my procedural logs and some of my ultrasound cases as well. But I did, a bit like Simon said, I did, it was like an advanced sort of reflective process. And I used as many cases as I could. And tried to keep them broad and with lots of different examples. But yeah, I'm just looking at my submission, not just the bit where the GMC put ticks to accept. But it was, yeah, everything that Simon said. It's good to get Simon's perspective as well, because obviously we're as people who've submitted it, it's sometimes hard to see the other side about what it was like to, from their point. But it's very broad, and the more you can demonstrate, the better. And this, my generation wasn't really a reflective generation, so this is it's quite a new thing for me. I think
it still isn't, is it?
It's still
I would hope that hasn't changed. What I've put in the chat is a presentation which I did, which was done along the lines that we've said. So you have an introduction and then a factual description of what happened. So this was actually a serious event or a significant event reported to the clinical governance. And then, so you break it up, you have the introduction. So like Simon says, you've got to make it easy for them. So you're sort of telling them the background, then the factual side of things, and then your reflection and the insights that you've got from this case, and break it up in that way. And the other thing is that, Simon, it must be anonymized, mustn't it? There must be any patient identifiable data in there. So that means no numbers, no names, there mustn't be anything which could lead to the patient being identified.
Yeah, and it's just the patient you anonymise. You don't anonymise all the doctors because that's part of their professional duties. The one exception, if you're investigating a doctor who if you're having issues with a doctor, and that's part of you won't be in this section, but in other sections, you might want to anonymise if you've reported a doctor to the GMC who that doctor is, for example. But generally leave the doctors' names there because that's part of their professional duties and expected that you have that. So I have seen people who've anonymised all the WBAs who did them, which kind of makes it pointless for us because we don't know what grade they were, etc. So yeah.
I used a coroner case within mine as well, and sometimes as consultants we involve the juniors in coroner reports, and you always feel a bit, but it's actually a really important part of the process. And actually, if you think about this is going to really help my CESR application, I would definitely get involved in them because they tick all the boxes for learning and development and reflection, etc. So strongly encourage, although they're horrible to go through, they're really, really good. And there's a structured way of reporting on them. So the trust normally gives you the structure, so it helps you fill in the form correctly. But I use that in mine.
Wonderful. So I've put the SSG guidance that's there in the SSG document in the chat box for everyone to just read again. There was a small question which was, do we need 10 case histories per year to be demonstrated, or is it 10 case histories in total? Please correct me if I'm wrong, but I think it's 10 case histories in total over your entire training period. Okay, and Simon agrees. That's great. We'd like to move on to the next section, but if you do remember to ask any questions, please put them in the chat box and we will surely pick them up. The next section is, we're going to start from section 11, which is the 360-degree feedback and multi-source feedback. And James, if you wouldn't mind telling us in 1 or 2 minutes, just giving us a background, and let's start off with what we should put in our 360-degree feedback and multi-source feedback section.
Just remind me, is that when you ask the consultants for the structured feedback, is this the same as the structured feedback they have to do in terms of each when we ask or is that completely separate? You just got to remind me, because I remember there was a form I had to send to about 5 consultants.
No, that what you're talking about is the structured report.
Oh, right, okay, because that's really.
So it used to be 6 in your day. It's now 4 consultants, many especially, who fill in the report. It's quite an onerous report.
Oh, it's a really onerous report.
That is separate to this.
Yeah. Okay.
The important point about that is that you need to help the consultant write the report, and actually basically write it for them. Otherwise, yes, I can see Simon recognises this phenomenon.
Sorry I know it's not my thing, Priya, but just to mention about that, it is a really, really onerous thing that the consultant has to fill in, but also they use it in their assessment. So very, very rigidly, and actually all my feedback that came back from when I got through, it used elements of that feedback to give the evidence that was required to say that I was competent. So it's absolutely vital but it's not an easy thing for the consultants to have to do, and they do need a little bit of hand-holding, without any doubt, and it's not something you can just, and it's also you've got to think about who you give it to, because it's if when you're giving work-based assessments to certain consultants and you never get a reply from them, they're probably not the best people to fill in this form because they need to put a lot of effort in, a lot more effort than a work-based assessment. No, but the MSF, so as part of a non-trainee, because you don't have the annual reviews, you have to go through the appraisal process. And as part of appraisal, when we revalidate, you have to do lots of MSFs, and it's a very similar process. So you have to send a number of forms for a multidisciplinary team that work with you to feedback on, from nursing staff to porters to consultants, etc. And it is really important that it's a really important port, because obviously it tells them a lot about you, and what people think of you, and often there really is a competence-confidence mismatch with people, and that really draws that out, because when it's done through the GMC, it's a very open and honest process, and usually it's anonymized, and people are fairly honest about what they think of you, and that's what it should be like. And it needs to be, I can't remember how many it has to be now, in terms of the numbers.
You have to send out 25, and then they randomly sample. Is it?
Yeah, so it's a lot, isn't it? So it's a heck of a lot. So you can't just let your mates. Yeah.
And it has to be a certain number. I think it's at least 10 of those have to be non-medical, I think. Is that right, Simon? Something like that.
So it varies from trust to trust, because the trust set the rules. The GMC suggests for both patient and MSFs 34 sent in. Now that's not achievable for most people. Well, for patients anyway. So our current OUH says you've got to have 15 respondents, and obviously given a 60% failure rate for most surveys, you've got to send out about 25 to get 15 back. Yeah. The evidence, interestingly, is that 12 is sufficient, and actually you can go as low as 6, provided the process is truly anonymous. That's the key for multiple feedback. But as I say, so our trust is 15. The GMs for the CESR assessment, there's not a question of how many you have to have, because you're complied with your revalidation rules, or most people do. But you must have at least one MSF, and you must have a good spread, be truly multi-source. So you can't just send it to your consultant colleagues. So there's got to be a spread of the medical fraternity, and then, as you say, 10 non-medical. That can be admin staff, radiographers, nursing staff are quite keen to fill these things on you, I find, positively or negatively. And then the additional bit that you need to demonstrate is that you've thought about this and reflected on it. Now, most people get very good MSF, and it's very easy to write reflections, say, oh, it's pleasing, better than I thought. But if there's any adverse comments or any lower scores, you really need to show that you've thought about it and done something about it. And that should be in your appraisal process, because you usually do this a couple of appraisals before revalidation. So you can do that process if needed.
And do you have patient as well? Because we do that within the revalidation process. So that's the tricky one, because you're not supposed to touch those reviews once they've been done. And it's so easy just to ask someone in front of you to sign something, and then but that's, that comes across obviously really badly. So there is a way that people do this effectively when you're on shift. I mean, I remember what I did. I had a box that I asked people to put the forms into when they'd fill them in, rather than letting them go home with it. Because if they go home with it and have to send it somewhere, it's less likely to get any yield, because people just probably put it straight in the bin. But so by putting a box there, and I got a member of staff to then collect them all and send them. And the GMC have their own structured forms that the patients fill in. And when you're working in minors and doing it, they need to have, as a consultant, when we do our revalidation, it is challenging because we work slightly differently as consultants. So often what we do is we'll sit in minors and do a load of minors, but actually for this process you need to show that you've seen a variety of patients. So and it is a challenge because, you know, a resus patient isn't going to be straightforward, but it'd be good if you can get them, and there are opportunities to do that, and definitely some peds, some parents, etc. But you got to work out a way of doing it that works for you and is easy and sensible. I used a box. I don't know what you guys have done, Simon. When you've done your validation for the patients, what have you done?
So I've kind of what you did. The important thing is that the patients are assured that it's anonymous and you have no part of the process. So what I tend to do is give them an envelope to seal with a clipboard, with the form on, say, could you fill it before you go? And then I explain that they need to give that to a nurse or give it to the secretary, or post it off to the MDO who will collate them all. And I'll have no part of that process. They can be honest as they want with what they say. The evidence, like with MSF, the evidence is that it doesn't matter whether you select yourself or it's randomly selected, the outcomes are generally the same. And that's because nice people are nice and get nice reports, and evil people don't realise they're evil. And so
yes,
people who
and they just assume that people like them. Exactly.
So the evidence is you're allowed to select. Some people talk about making that process anonymous and getting somebody else to do it, but that's not really feasible in our setup. You can't ask a nurse like you could in a clinic to see all your patients after and give them a form. So I tend to give them the form, but then make sure they're assured, and the process afterwards doesn't involve me at all. And I use an envelope that they give a nurse.
Yeah, that's right. So I did the same. So you give them an envelope, it's sealed and put into a box, so that you have no part in the secondary collection of that.
Yeah.
I was just trying to find an online form actually that I could post a link to in the chat. I'll carry on doing that whilst we're going through. But if either of you have one to hand, let me know.
The GMC website has examples of patient surveys and MSF and what the GMC think is reasonable, which is slightly different. Trusts usually have a lower requirement. Yeah.
So I'm just going to try and summarize everything that all the points that we've just discussed. So please stop me if I'm saying something which is incorrect. In the evidence that you submit, which is 5 years to GMC, under the section 11, which is multi-source feedback and 360-degree feedback, you need at least one completed cycle of MSF. This one completed cycle of MSF or 360-degree feedback must include colleague feedback and patient feedback. Simon, you mentioned the number 34, and maybe it should be half and half. And James, you said the patient feedback should come from a variety of cases, minors, majors, resus, daytime, nighttime, all of that. And colleague feedback, as you said, Simon, should be your consultant colleagues, registrar colleagues, SHO colleagues, nursing colleagues as well, and any other people. So those are the people you can get the feedback from. Collect all of this feedback, which could be 34 or more if you want, but there must be at least one cycle. And then if you are able to see it and there's any adverse comments in it, you must be able to reflect on it. How to do this feedback? Each trust is different. And at our trust, it's an online system, and you have to give email addresses of colleagues. The form is sent to the colleagues and the replies are got back without us knowing anything. And James, your idea of putting everything in a box is what I did as well for my patient feedback. So I had 15 envelopes, 15 patient feedbacks. And after I had seen a patient, I asked a friendly SHO or a nurse to with a ready clipboard and a pen and a form with an envelope, and ask them to take all of that to the patient and then collect it, fold it, put it back in the envelope, and put it in my box. So you have to get a friendly colleague,
and you have to give them a pen as well. I mean, don't forget the pen.
As well. Give them a pen as well, along with the clipboard. That's right. And
I think that's the most difficult part, finding a spare pen in A&E.
No, it is the most important thing in the department, isn't it? Your pen.
I bought a pen, then tied it to the clipboard.
Oh yes, Simon, I did that too. Yes, so that then otherwise the pens get lost. So I think I've covered it all of the facts that you need to do a 360-degree feedback. Helen has put a link for what you could use, and GMC has both, as Simon said, a patient feedback and a colleague feedback template if you need it. Does anyone have any last comments on 360-degree feedback and multi-source feedback? Any questions in the chat box, Helen?
No, nothing.
Okay. Shall we move on to the next section? The next section is number 12. And on my list, I've got it as awards and discretionary points. That's the next section that we need to fill in the GMC divider pack. James, do you want to give us a 1 minute? What could go in this section?
I found this the most intimidating section, actually, because when you see the term awards and you just think, oh my word, what have I done? And I can't put my my cycling proficiency badge in there, can I? and so to me, because there's a number of things that just used to give me stomach, make your stomach drop, and that was definitely one of them. But it's actually quite interesting when you start reflecting on what you have done, and it's not as difficult as you think to find accommodations and things you've done within the department or other departments that you can utilize in this group. I mean, I'm just trying to, because I've got I'll pop you onto Simon to see what his views are, but I'm going to have a look at what I actually submitted. Just, I'll come back.
Yeah, Simon, what could go in this section?
Well, interestingly, this is commonly a very empty section. Because you don't get discretionary points usually until you're a consultant, and actually they're quite difficult in many organisations to get them even when you're a consultant. This is just for for people who've been working maybe in a social special role for many years. It's a historical hangover. So often it is a very empty report. I'm just opening up.
It says not required on my submission. I did submit something, and I can't remember what it was, but it did actually say on the GMC response to all my tick boxes, they tick everything, they put not required.
Yeah. So often there isn't an awful lot in this section. If you've got, if you've been awarded and, I don't know, an NHIR grant, or you've got something really, really weird and interesting like that, or you've got commendations from your medical director, for example, Priya. Do that. That sort of thing put in there. If you got a first interface degree, whatever. Yeah. But actually, this is usually a fairly sparse section.
But something not to be anxious about because of that. Because it's one of those that you think, especially when you're thinking about it in terms of dividers, you think, oh my word, I've got an empty section. But it's not. It doesn't look as if it's got a huge amount of weight.
Yeah, no. So I really wouldn't worry about it at all. And as I say, it is a largely empty one. In most applications I've seen, it is empty. It is empty. So yeah. But if you have achieved something, a bit more than cycling efficiency or Duke of Edinburgh, but above that, then you'll put it in the medical field. But I wouldn't worry about it.
Thank you, Simon. That's really helpful.
Yeah, great. Helen, do you want to tell us what the next section discusses? I'll try and summarize.
Absolutely.
So you've said, Simon, 1, it's all right for this section to be empty. James, you said, don't get anxious or panic if this section is empty. 2, you can put in commendations that you've received from colleagues, senior, junior, you can put commendations. And if you've been awarded any certificates, grants, or even a letter which says nice things about you, then you can put it under this heading. The section exists because there may be evidence in your last 5 years of practice that can fit into this section, and that evidence may not fit elsewhere, and therefore the GMC divider pack has this section. But if it's empty, it's completely fine.
Yeah, and I think also just to echo that, so letters, yes, but even sometimes an email from a colleague which has, you know, praised your you know, your clinical management or your kind of team working in any way, I think, Simon, that would also be appropriate to go in there. Am I right?
Yeah, yeah,
yeah.
There's a question in the chat for either of you. Do these awards have to be in the last 5 years, or can they be older?
So I think that the sort of bottom line is, it's nice if it's in the last 5 years, but you can submit stuff. The GMC can always say no. If it's a big award, then yes, you can go back longer, because it shows that you were good in the past. You better be good now, but you were good in the past. Yeah.
Wonderful. Helen, next section is?
Yeah, so the next section is our PDPs, or personal development plans.
And Simon, do you want to give us a 2-minute, what can go in this section?
This is probably the easiest section to fill in, to be honest, because in this day and age, and again, lost is historical because, you know, things were very different in the past. But in this day and age, we all have to do an appraisal every year, and that has a PDP in it. So actually, the bit about submitting your last 5 appraisals, which you have to do, you'll automatically cover this because your PDP will be in there, and you'll have reviewed it. You should have, if your appraisal process is correct, reviewed it the following year, and you'll have 4 PDPs that will have been reviewed and amended. So actually, this is a fairly easy section, provided you've engaged well with the appraisal process. Everyone has to engage, but there's a difference between engaging and engaging well. So yes, hopefully if your appraisal is a robust one, then it will have PDPs in, and you'll have met most of them, or at least reviewed them and refined them each year. So I think that's reasonably straightforward.
Simon, question for you.
Yes.
Is it okay for me to write a summary letter under this section and say, I have put my appraisals elsewhere in another section, please look at that? Or should I
Yes, so the GMC,
and put it again in under this section for ease for the assessor?
The GMC doesn't like to put things more than once in this, because it becomes, you know, I'm currently doing one which is 2,500 pages long, and it's just a nightmare. Particularly has to have an indexed it at all, so I've got to dig through every single page to find the stuff. So indexes, as I said, for each section is really useful. You don't have to put everything, piece evidence in every section. You can what reference it. So you can have a summary saying, I've engaged with you know, my PDPs or in my appraisals. This is a summary of how I've engaged with the process and how I've modified my PDPs over time. Please see the appraisals for the details. Yeah, a one-page summary in front of every section is really helpful for the appraiser, and it shows you've also reflected on the whole process itself. And
that's a good bit of advice, actually, isn't it? Yeah.
Just to give everyone a little, when I first came to this country, doing a PDP was a new process for me. So there may be people watching today who may not understand exactly what PDP is, how it works. So I'll try and tell you what I did, and then you can correct me, Simon and James. It is 3 to 5 action points that I have decided that I will try and achieve over the next 1 year. And I will put the action point, and then I will write my idea of how I'm going to achieve it. This is my PDP at the beginning of that particular year. At the end of the year, when I'm having the appraisal, what I'm supposed to do is I have to reflect on each action point and say, did I achieve it? Yes or no? If I did not achieve it, then why not? If I did achieve it, then how and what I did. and I have to reflect on each action point from my previous PDP. And then I have to have another 3 to 5 personal development plan action points for the next year. And what I have to show is this bit that I am making sure that I'm developing myself, and I have my own plan in my head of changing and developing and growing every year, which is what the GMC want to see. Am I right?
That's spot on. That's spot on. Yeah.
And remember, you don't have to achieve them.
No, yeah.
You have to reflect on why you didn't achieve them and what the barriers were, what you're going to do about achieving them, or if you still need to achieve them. But so yes, sometimes, yeah, I have them regularly with me. My PDP has one element which is the same each year. You know, I didn't achieve it last year. I'm going to try again this year. But this year's been particularly interesting for that, because I've had stuff that's been on my PDP for 2 years I haven't achieved because I can't go on the courses to achieve it, type stuff. But the one other thing is that you have to make it relevant to your job. So you have to think about where my sort of unmet need or my educational need is.
Yeah.
And then develop a sort of smart plan from that in the PDP. Yeah.
And reasonably achievable as well. So it shouldn't be sort of, you know, I want to get a knighthood by the end of next year, you know, that kind of thing.
It takes at least 2 years, doesn't it?
Yeah, yeah, exactly.
Yes. So that is what a PDP is. And the GMC want to see that you've thought about your progress and development and you've actually worked on it in that year. That is what they want to see. And as Simon says, if you haven't been able to do something in 1 year, it's perfectly fine, because we have lots of aspirations, but sometimes things don't work out and we get hit with a pandemic or other things happen. So it's fine if we can't achieve it. Participants, do you have any questions about personal development plans? Basically, if you're submitting evidence for 5 or 6 years, then under this section, you should show evidence of personal development plans for each year. That means there must be 5 or 6 PDPs that you've had, and your reflection on each year's PDP, which is usually required in your appraisal process anyway. So just pick that section up and just write a summary in this section. Any last points to add to this section? No, okay. Helen, do you want to tell us what the next section is and who we are going to invite to give us an introduction?
You're on mute, Helen.
So we've now covered so far, we've covered case histories, we've done our 360 degree in MSF, awards and discretionary points, PDPs. So the next one is participation in assessments, assessments and appraisal process. So I think probably, I mean, I don't mind if either of you would like to kick off with what sorts of things people can be expected to have done to put evidence into this part of their application.
So you've got to remember that when you go through a training program, you've got regular assessments that are agreed and then reviewed each year, and you have to meet those requirements, and you've got to be equivalent to that, and you've got to demonstrate you have that kind of level of equivalence. So I think this section is quite important because you've got to demonstrate the same kind of level of patient assessments that that you've submitted. And Simon, in terms of using the e-portfolio at this point, we can use that, can't we? So that's what the annoying thing about the GMC application is, it's all paper, isn't it? And we live in an electronic world, and it's so, and I think I have to say, I can't say this enough, but one of the biggest irritations is everything has to be printed out and then every page has to be signed by someone. I think Simon Smith signed all of mine.
That's changed. Yes, I do.
Oh, has it?
Your stuff. One coffee's all we bought me for that.
Yeah. I should have got half a coffee.
So it's electronic. Most of the things, I think, when I submitted mine, I did. I could submit lots of things electronically.
Okay.
So now the process is fully electronic.
Yeah.
And the signing off process is a verification process.
Yeah.
So that as a verifier, people will send me stuff saying, the evidence they're submitting, I have seen it, and it does come from where I work. Rather than signing every bit of paper, we now just sign a summary of this is all the evidence I've seen, and I know it's true and valid. So it's slightly easier for the verifier nowadays, and it is all electronic, which actually makes it quite. I think it makes it more difficult. You've got to scan stuff in, and it's just a nightmare. But that's just my old thing. Yeah.
To begin with, I'm just going to say the section name again, just for everyone. It is participation, the CESR applicant's participation in assessment, appraisal, and appointment process. So I have to show that I was assessing someone, appraising someone, or appointing someone to a job. So it's a management type section, not a clinical.
Oh, sorry. Yeah, sorry.
Type section. Yes, there is another one, James, which is similar, but it's to do with patients. So it is very confusing. Another name, but
yeah, and apologies for that, because it just shows how difficult this whole process is, isn't it?
It is very confusing sometimes. But am I right in thinking that is what I have to put in?
Yeah, I mean, it does help if you're in a position where you have you've been acting up as consultant level for a period of time. For this section, it is much harder as a trainee to do this bit, but the consultants in the department need to assist you and help you in doing this. And in terms of being involved in interviews and appointing people, it's still possible, but it is really difficult. There are regular appointments and regular assessments that are done all the time, and there's loads of opportunity, but you actually have to be proactive to meet that opportunity, and you've got to get willing seniors to support you in that, because it's quite a lonely process. It is a lonely process going through the CESR route. And I think that's probably the one thing that I remember the most, is you are completely on your own, but you do have to have this kind of really close support from a couple, not just one, but a number of senior colleagues to assist you through it, particularly through these kind of sections.
That's right. When I had to show some evidence about how I was involved in appointing someone, I approached the recruitment lead consultants in my department. So in my department, we have a recruitment lead person consultant for SHO level doctors, and there was another lead consultant for recruitment for middle grade level. And then I approached both of those consultants and said, if you are in the next year or 2 years doing any recruitment and doing any interviews please may I be involved? And then of course they said, yes, you can be involved. And then what I was asked to do for the SHOs was come up with a set of 5 questions, clinical questions, that you're going to ask. And then along with the lead consultant, I was a registrar then, we asked all the interviewees these questions, and then I had to sit and along with the consultant say, okay, this person answered the question well or didn't answer the question well. So it was a process that I had to be involved in, and the same thing with the middle grade. So that's the evidence I showed. And the evidence that I actually put in the divider pack was letters from both these consultants saying, yes, Priya has been involved in the recruitment process and in the interview process, and this is how she did it, and this is how she was involved. So I got letters, and I also put in the questions that I had designed to be asked at the interview. I put in that as another section. Simon, do you want to tell us the difference between the three and what can go? Yeah,
it might be useful to do that. Helen has had a hand up though, so
Well, what I thought might be useful is if there's any of the attendees here, if they have had experience of how they have gone about getting this kind of experience in their own particular trusts, then I really would be great if anybody wants to unmute themselves and offer just more ideas really about how you can potentially get involved in this process. The other thing I wanted to say was, so for example, that's it's not really quite appraisal, but I've been doing a bit of mentoring for the medical students in the department. Is that sort of thing, would that go into here, would you say, or was that?
Yeah, absolutely. We'll wait for people to think about what they're going to say. I was going to put another more suggestions in. So just to remind people the difference between appraisal, assessment, and appointments. Appointments is very straightforward. It's giving people a job. Appraisal is different. Appraisal and assessment is an external process. Okay, so to the person. Okay, so I say to people, this is how good you are now. Okay, it's open. It's like an exam. An exam is a form of assessment. Okay, so the results are published. It's just what standard you are at and what standard I want you to be at, and did you meet it? That's what assessment is. So a WBA is usually an assessment process. Okay, they can be formative, but they are usually summative. Okay, an appraisal is an internal process. It is what you've done. So an assessment is at a point in time. Is right now, right on this day. An appraisal process is this is what you've done. This is where you need to be. And it's personal. So you make it up, you decide on it. There's an appraiser who helps you with that process, facilitates it, but actually it's all about you. Okay, and it's not against the standard; it's against what you have done. So there's a timeline there. So it's a bit of history and a bit of the future, and so they're linked, but they're slightly different. So lots of examples of how you can do this. Okay. Most trusts do allow the more senior non-trainees, so clinical fellows, to go on education supervisor courses. Okay, and the deanery allows you to do that, so you can go on the ES courses, and then you can do some supervision for foundation trainees. Most people, you can be a supervisor as a senior non-trainee. Some of the Statman training covers this. So at our trust, you can go on your values-based appointments course, which is a day or two, which tells you about the appointments process and how to achieve it and how it works. And the other thing, which is slightly linked to it, is if you're ever involved with performance or people management of juniors, that is also part of this, because it is both assessment and appraisal mixed into one, often in quite a formal process. So, if you have a task with going off to, manage a trainee because they've had complaints or because their performance isn't quite what it should be, that is also excellent, because you have to assess them and then you have to do a bit of an appraisal to improve their performance. So that's kind of the suite of ways that you can also demonstrate this. Has anyone thought of any points to make?
I had a hand up from Jason. I don't know, Jason, if you want to unmute yourself.
Hello, morning everyone. Most of the things I was going to say have been mentioned already. I'm quite lucky in my trust. They're very aggressive in pushing me forward for these sort of things. So I've sat on an interview panel and then reflected on that and included sort of because they asked me to formulate the clinical questions for the interview process. So I reflect on the fact that was my role in the appointment process, etc., etc. Most people who have access to portfolio who do workplace-based assessments for juniors, it should automatically keep a copy on your own portfolio, which I plan on including. But yeah, everything else I was going to say has sort of been mentioned or touched upon already.
Thanks, Jason. We've got a couple of questions here. So one question in the chat, does a placement supervisor for a medical student and physician associates, can that be included in the section? Absolutely.
Yeah, it's about all staff. And if there's a management line and you're in that, yes, it counts. Okay.
Perfect. And there was, I think it was similar to this question actually, Bilal, I'm a supervisor for nurse prescriber. Again, I think we've answered that question. So that would be a yes for any staff really, as long as you can demonstrate the process that you've been involved in. Okay. So I think if that's any more questions, obviously people can put them in the chat, but if we move on for timing, so the next, so we've done, so the next one, so we've got three, so we've got logbooks as the next one, Simon, if you're happy to kick off with that one.
Yeah, so I'm going to do logbooks and section 15, which is consolidation, cumulative data sheets, summary lists, and annual caseload, all as a one-er, because they are quite similar and it's useful to tease out the differences, I think. So the first thing to remember is that this platform is the GMC generic platform. So it's for all specialties. So these sections will look very different for some craft specialties, such as ENT surgery, as they will for a GUM doctor, for example, but they have to have a generic platform, okay? So rather than worrying about the specific title headings, I would refer to the SSG, which sort of summarizes it a bit better than just than the GMC does, quite frankly, because it's a generic thing. The other thing to remember is that it's an evidence bundle. We've been quite reductive in breaking this down to sections, but actually it's the suite of evidence together which forms what the assessor will look at, not just one section at a time. Okay, so you've got to think about how these two sections complement, for example, all your portfolio stuff with your WBAs, for example. Okay, and how that covers the curriculum in its entirety, all things considered. The other thing, just on a process point, is to kind of point out that the first stage of your submission involves an assessor from, an advisor from the GMC going through your documentation, and they're not as well versed and not really interested in SSG. They're interested in compliance with the platform and their expectations of what the GMC is. So they often come back to you with queries about, well, this logbook doesn't look like what I'm used to, because the last one they did was an ENT surgeon. So it's kind of, there's a kind of process with the advisor, which is slightly iterative, saying, well, no, this is what is expected. And sometimes you change it a bit for them, sometimes you don't. But there is a bit of a discussion that can go on with your advisor on these sections. So the first thing to think about is what you're demonstrating with all of this, okay, and what the aim is. And again, a summary section is very useful. Okay, we've already talked, I think, last time about the mapping to the curriculum, but actually what you want to is to summarize the evidence and how that demonstrates the curriculum as well in each section. So when it comes to the logbook specifically, you've got to divide up your thinking into, is this procedural, which is what the GMC is very familiar with. It's what have you done and how good are you at it, okay? And the clinical stuff, which is a bit more domain, which is about what cases you've managed, okay? And then you also have to think about, is this a formative or a summative process, okay? And how it segues all the other evidence, okay? So a logbook for procedures, very straightforward. It's just a long list of, and it can be a precise list of all the procedures you've done. Most people don't do that. Some people just put a summary of, I've done 50 central lines, 50 art lines, 50 intubations, etc., which are just raw numbers, okay, as the summary, and then some detail about the specific things and stuff you learn from it if it's formative for the procedures. That's fairly easy to do in this day and age, as long as you keep a record going forward. And some of it will have been done by WBAs rather than so particularly the formative bits, and some of it will be done in your core, the core training or your secondments. So the procedure stuff is conceptually probably the easiest bit to deal with, because it's just a list. And actually with procedures, the proof of the pudding is in the eating. You're either successful or you're not. They've either had complications or they haven't. And it's useful to include some of those things, a couple of failures look real, things like look real, and a complication or two. If I see a logbook with 50 art lines and no complications, I wonder, and no failures, I think, well, is that real? So it just, it's like you always invent an odd number when you're reporting stuff. You always invent, you always have a deferred success and things. So that's the procedural logbook. That's fairly easy. The difficult bit is the logbook of cases, because this is not that well defined in SSG. It just says you've got a logbook of cases that cover the breadth of the curriculum, as it normally says, breadth and depth of the curriculum. And it's a slightly subjective number, is what you think. Okay, but the logbook of clinical cases is essentially an in-depth reflection, it's not as deep as the case histories, but a really in-depth reflection of some sentinel sort of formative cases across the spread of the curriculum. The number that I would suggest, and yeah, there are no hard or fast numbers in the SSG, is probably about 30 cases in each section, probably a bit more for the emergency medicine section. And remember, what you're trying to do here is demonstrate the core bits, if you haven't got that, okay? So the two bits that are really important are the acute medicine bits and the pediatric bits, okay? Because most other stuff is covered in the curriculum anyway. But demonstrating that you've done some acute medicine and you're still current in it is probably a bit that trips. In fact, it certainly tripped the last lesson I did. That's what they deferred their success on. They hadn't done any acute medicine and they hadn't demonstrated any competency in that. So yeah, what I'd like to see, or I would like to see in the last assessment, is some time in acute medicine, for example, in this case. Now that doesn't have to be necessarily a 6-month post or a 3-month post. It does say in the SSG that OLOTs can be done in the emergency department, but you're supervised not by emergency physicians. You're supervised by medical registrar minimum, preferably consultant, okay? And the really good ones will have, the 3-month secondment with a beginning and end placement supervisor report, possibly a summary letter saying, yes, I've spent some time with you and I've seen you perform, a couple of WBAs, and then a logbook of at least 30 cases where you described what you've learned and what was different about, this isn't just an EM, this is AM, so what is different? So some of the care that's been going on and you're involved with after the 4 hours. And similar for pediatrics, so what have you learned from it? How it's changed your practice, a little bit of reflection on about 30 cases. And that can be done very much in the department because PEDS is allowed ST3 level to be in the department, provided your department is big enough. And that comes on to the sort of caseload statistics that they always ask for, which is just checking your department is of the right size, okay? So the requirements are, if you're going to count your PED stuff, the department must see 16,000 kids a year, okay? So you have to prove that your department is big enough. And they basically want to see that you've been in a reasonable sized department with a reasonable spread of cases. Just anecdote time, I once went to an emergency department in Gibraltar. It was a naval emergency department, so it just served the Navy. I wandered down, the room was about the size of this room, had 2 beds in, and I looked at the case reports and it has 3 patients a day. The last case was a squadron that couldn't reach the itch in the middle of his back. So they just want to make sure that you're not working in that sort of department. and you're seeing a bit more cases. So that's the sort of departmental caseload stats that it asks for. It's just to show that you're working in a regional department and you meet the PEDS requirements. So that's sort of logbooks, and that combined. So your case, your summary list and consolidation reports are essentially a list of all the cases you've seen. Okay, is probably the easy way to do it. And what they're trying to see here is you're seeing a reasonable number of patients. Okay, either as supervisor capacity or as a primary care capacity. And most EPRs these days, that's fairly easy. And most of them will actually give you a bit more detail. So what they presented with, what the diagnosis was, what the disposal was. And that's really useful for showing two things. Firstly, you're doing the work. And as a rough cutoff, we expect at least 500 patients per year for the emergency medicine bit. Well, it's better that when you get below 500, you start to think what you're doing with your time all day. Obviously pro rata. So a list for last few years, lots of all the patients you've seen with as much detail as your EPR will allow you. And that just shows us that you are seeing the breadth of the curriculum. So you spend time in research, you're seeing enough kids. Some people split the kids and the adults out to make it easier for us, and that is useful. The numbers game, and it just shows you're doing the spread. So it doesn't tell us anything about the quality. You could have been seeing them all terribly, and that's why you need your medical reports, your case histories, your logbooks, and the WBAs, because the whole suite together tells you you're doing the work, and you're sampling a few that show us you're doing it well. So that's kind of what these two sections should show. And again, I'll say it again just to labour the point. A summary at the beginning is really helpful to say, look, this is what I'm trying to show with all this, and these are the raw numbers. This is number of cases in my logbook. This, it just helps signpost us to what you're trying to show with these things. Is that made it quite complicated? Have I overcomplicated it, or is it clarified?
So I guess clarifying. So in terms of logbooks, you've got your procedural logbook, which is a relatively straightforward list of stuff you've done, which could be a logbook you've made plus minus work-based place assessments to back it up. Talk about successes and failures, complications, make it look real. Because it is real. Obviously it's real. And then you've got your procedure, so your case procedures. So you said have about 30 from each section, and you've talked about acute medical cases and you've talked about pediatric cases, and they're not as in-depth as your case histories, but kind of like showing what you've learned and what perhaps was different or useful. I've got a couple of questions here from Jason. Jason, I'm happy to read them out, or you could unmute yourself and just ask. So oops, sorry, I just managed to go up. Okay, so this is, and I think we talked about this last week, Jason, but just for clarification, so for procedures, and particularly rarer ones that you maybe don't do as often, chest drains, cardioversions, would it be okay to take a list of specific procedures, get it that signed off by a supervising consultant, for example, who is happy to say that this doctor is competent in the following procedures? So it's a signed copy of procedures with a, to say this doctor is competent. Is that satisfactory for it to be sort of countersigned by departmental consultants? Or does it have to be?
So you can be as creative as you want with how you present the evidence. Okay, it's got to be, it's got to be valid, as it were. So you set us to believe that you haven't just made this up, as it were. I think there's no problem with a sign off. It's slightly easier for those that have been through a training program for the core specialties, because most of this stuff is in the core specialties, isn't it? It's because you will have gained the competencies, and they can't argue with that. Now, if that's more than 5/6 years ago, it is quite important that you demonstrate you can still do those procedures. And actually, the easy way to do that is just do adopts every now and again. It doesn't have to be a huge suite of stuff. But, you know, but yeah, so it's slightly easier if you've been in a training context of some sort. But yes, a sign off and a summary sheet would work for me as an assessor. Yeah.
Thanks, Simon. And there's a second question, which I think it was not just Jason. There are other people who are saying, yeah, I'd like to know the answers to that. So regarding acute medicine, so Jason, I think you did acute medicine as a CT1, which was many years ago, but I imagine that as having done it as a CT1, you would have been kind of signed off for various things.
Yes.
Yeah. So your question is, how do you demonstrate that you're still up to date with your practice in acute medicine? Like, do you need to do another secondment or other work?
I find this the easiest to sign off in my portfolio, because obviously there's a huge crossover between acute medicine. It's things like peds, anaesthetics are the ones that are more challenging, obviously, but from an acute medical point of view, there's a lot of I mean, I was a supervisor for acute medicine for a period of time, and there's huge crossover with the portfolio. So my view is there's a lot of things that you can get signed off within ED without having to do an acute medical job. But Simon, is that?
Yeah, so if you've done an acute medicine job in the past, like that questioner has, then it becomes very easy, because you gain the competencies in the past. All you've got to do now is demonstrate that you're currently doing them, and actually say with acute medicine there's such crossover. All you have to do is demonstrate, you know, some WBAs of some of the more sensible cases, which there are a million of, and it's fairly easy if you've done it in the past. The problem many people face is they haven't got an acute medicine block. They can say, well, I gained the competence in the past, and I've got that experience. And then it becomes, you have to be creative about how you do it.
What did I do? I went and did a few shifts in the adult ambulatory unit because I wanted to learn about.
I was going to suggest that. I was going to say
how that unit works.
Because SDEC unit, essentially.
Yeah. So SDEC is same day emergency care type unit. So in my hospital, it's called the adult ambulatory unit, and I did a few shifts there and saw patients on the same day. The other thing I did was I requested a few of the medicine consultants if I could do a few takes with them. So I did about 10, 12 takes with a few consultants who would let me join them. And then I did rounds with them. I discussed cases. I wrote up notes. I reviewed patients. I prescribed medicines along with them and attended handover. So I did a few shifts on the acute medical take as well. So joining up those two things, I think then I could show that I was still continuing to do acute medicine. And the third thing that I did, actually two more things, was I wrote up a summary logbook type list of about 30 patients that I had seen that we discussed previously. So age and gender, what was the presenting complaint, what I did, what I learned, reflections, learning points, action points, 30 of those cases. And then I also had some letters from the acute medicine consultant saying, Priya has worked with us, we've seen her doing acute medicine, and she continues to have the competencies that she had gained in the past. So I got 2 or 3 letters from acute medicine consultants saying, I'm still good at it. And those are the 4 things I put in acute medicine section.
And I think it's important to remember that actually for acute medicine specifically, what you're assessing is core training level. You're not expected to be medical registrar level or consultant ED level. All you're expected to show is that you are equivalent to a core trainee who's done 3 to 6 months of acute medicine. And that is, dare I say it, a fairly low baseline, having been a medical SHO registrar myself.
Thanks. I just want to check, Jason, if we had answered all of your questions.
Yes, thank you. Thank you.
Excellent. We've got another, I've got another question here from Pan. And the question is, would you need to refresh all of the medical competencies? And I think the example you give is an abdominal drain, which is part of the ACCS medical procedures, but obviously we don't do those in A&E. I've never done one. Or is it just those ones where we've got ongoing need to be competent in them?
So no, you don't have to demonstrate it all over again. You have to demonstrate your currency, and you've sampled the curriculum. Remember, if you're a trainee in a group medicine block, you only have to do, I think, 2 WBAs in cases. So actually, it's a fairly low level of evidence that a trainee would give. So same for non-trainees. And if I think back to the last 10 applications that I've assessed, only 2 of them had abdominal drains or paracentesis. And both those had gone off and done it just because it was on the list. It's of no relevance to how good an ED doctor, because I haven't done a drain or paracentesis in 15 years. And I've only come close twice in my ED career. So yeah, I wouldn't worry about repeating everything. All you're doing is again sampling, with all these bits of evidence. Yeah.
Jason, you've got your hand raised.
Hello. Yes. I've got another question that has just occurred to me. I understand what you're going through now is what we send to the GMC. What sometimes throws me and my department a little bit is there's another document on the RChem website, template of evidence versus competence. How does that play into everything? Because that covers the entire curriculum. So we've been under the impression you've got to show evidence for everything on that particular list to then send to the college, which does include random things like paracentesis and pediatric tracheostomies and things like that. So we're not quite, my department isn't quite sure how we square that circle, so to speak.
Yeah. So let me say that the competency document is an excellent document for the assessors. It is really useful when it's the first piece of thing I come across in domain 1. I can look at it and say, yeah, they've got bits. Now, you do need bits of evidence in almost all of them. As I said, some people don't have the paracentesis, so you don't have to have it in everything. Okay. And
start doing some DPLs. That's what you're saying, Simon.
You don't have to have something in everything, but so the more common stuff you have low evidence for. Remember, the evidence is, people have this obsession with evidence being WBAs. It is not. Evidence is evidence. So your logbooks are evidence. In fact, you've got FR Chem is evidence. This is all evidence of competency. All your e-learning and CPD and courses you've gone is evidence. And simulation is evidence. So yeah, you may not do a pediatric tracheostomy, of course you won't, unless you're very, very unlucky. But you'll have been on an HLS course, an APLS course, you may have done some simulations, you may have done some e-learning about tracheostomy. I did some last week actually, on tracheostomy, and I'd put that evidence in there. It's not a WBA because I haven't come across that case, but it is evidence that if I were to meet that case, I could probably have a stab at it, as it were. Excuse my pun. So that sort of explained it. More evidence is good, but just think about whether the evidence matches that domain and creative ways of filling it. Okay, and you don't have to have evidence in all the really minutiae stuff, although some people do. Okay.
Thanks a lot, Simon, for clarifying. And we've got a few more questions on the chat. So Bilal, you've asked about the RChem patient logbook spreadsheet templates. You said there's minimal room for reflective notes. Do we need more than a one-liner for what you've talked about, the case procedures, the case logbook?
Ideally, yes. Okay, so what most people do is put it into an Excel spreadsheet because that gives you more room.
Okay.
So just use the same headings, but in a different format. I suppose you could do it on Word as well, I suppose, if you expanded the box. But yeah, you basically need a bit more space than one line. I'm not saying it's an essay, because you know your case histories are the essays, but you know 3 or 4 lines, or you know a good strong paragraph is required for the, because you know it is a big bit of your evidence. You know.
Thank you.
So Simon, you've seen the acute medicine list, that logbook that I put together.
Yeah.
And I made it in Word, and I had about 2 or 3 cases on 1 page. So my each case reflection had about 5, 7, maybe 10 sentences in it. So that's how I did it, in case anyone wants to just take it out of the Excel sheet and just write it.
And the other thing is, these things are much better to do going along rather than at the end. You know, I know it's hard, we're giving you a long list of things to keep doing every week, but that is the easiest way to do it. Is to think, right, okay, let's from now on, I'm going to do one of these a week, one of these a week, and one of these a week, and by the end of a year, so you'll have an incredible amount of evidence you didn't realise you were collecting. That's what I do in my appraisal anyway. Shove it all in there, and then maybe you can take stuff out later on if it's too much.
Presumably, Simon, you can use some of the cases you've used for your work-based place assessments, because those are ones that you've already kind of reflected on.
Yes, there's no reason why you can't. Okay. It's useful to have a bit of a spread, and you know, one case doesn't cover all of these things. You can't say that's an abdominal pain, I'm going to reflect on that twice and get 3 WBAs on it. But yes, yeah, within the limit, absolutely, yeah.
Okay. Tom, do you want to explain your? You've put some things in the chat addressed to Simon.
It was really to sort of bring out the fact that if you. So one of the things with procedures is probably that if you there's a sort of saying with certainly chest drains that if you haven't had a complication, then you haven't done enough of them. And so what my point here is that if you do have a complication or something which is a result of a procedure that you've done, then my guess is that the assessment panel would not regard that as a bad thing, provided there's the appropriate reflection on it. Obviously, if all of your procedures involve the patient going to ICU or something, then that's probably not ideal. So Simon, it was just to reassure people on that, or make that point.
Yeah, absolutely. In fact, the one I'm assessing at the moment has put a couple of did not succeed when I tried to do the central line in, and then a little bit of why he thought it was, and you know, partly patient, partly human, lots of factors. Yeah.
Okay. So I think in the interest of time, we've got 2 more sections to cover. It's 11:30, so everyone happy if we move on to the next sections, and we can always address any other questions at the end. So, so medical reports is section 16, and I think then the one after that is going to be referral letters discussing patient handling. So, do you want to kick off with medical reports, Simon?
Well, I can just tell you what I submitted. That's where I submitted a coroner report, and the other reports that we do regularly in ED are police reports. And you know, quite often the consultants do those, but you know, it's really good chance to do them, and obviously they have to be completely anonymized, but it's a formal report that you have to submit. And I think I did 4 or 5 of them, and I think that was at that time was okay. So it'd be good to hear what Simon says about that.
Yeah, so people, again, you can be very creative with this. So coroner's reports are a really good example, and police reports are reasonable as well. I seem to remember, put me wrong, SCG says you only have to submit 3 medical reports. Is that right?
Yeah.
Yeah. So it isn't a big thing. What people usually actually put in here is some case notes. So you're straying on, it can look a bit similar to your case histories, but this is just demonstration that you do a good set of notes, and plus minus a little bit of complexity. So you don't want, you know, I've seen a sprained ankle, because that's a boring thing, but it's, you know, I've seen a complicated case, you know, good trauma case or a good sick case, and then some stuff that came on after it. So to show that you're thinking about it. So yeah, if you did an incident report on this case, or you did a there was a complaint about it and a complaint management, that sort of gives you an idea of the complexity. Or if you had to refer them on to, you know, to the high frequency users group or something. So some little added, or if it was a complicated medical legal case, so it was a sexual assault or something like that, that sort of adds a bit of spice to it. A really good example that I came across a little while ago when I was assessing some case was a chap put his case notes from a couple of traumas, and he said actually there was a long email trail afterwards where he'd said, so what you know, I saw this trauma, I asked for a trauma call to be put out. It was a family in a car, so it's a multiple trauma. The person in charge said it wasn't required, and as a consequence, I missed the kid's leg fracture, and I couldn't really assess the mother properly, and it wasn't ideal management. So I made these errors, but I think there's also this bigger thing about when we put trauma calls out in this hospital. And it was a very professional, very well-written email. And then all the subsequent emails were in a similar vein for all the people that he was involved, including the person he was talking about. And it wasn't a medical report per se, but it was a really good example of sort of complexities of problems and how he'd managed the incidental case and how he'd handled the sort of fallout afterwards, as it were. So that's you can be quite creative about how you do this, but basically it starts with a case and a summary and a report of that case, and then you build up from it. So it's only 3 are required. More is always better, but 3 is the minimum. So make it an interesting and spicy one. Yeah.
What about an SJR? You could do an SJR.
Yeah. Absolutely.
What's an SJR?
So it's a system judgment review. So post death, it's filling in the incident report. Now, every department will have a governance lead, and there'll be a governance management person as well. And it's probably worth linking in with them, because you can get involved in that process. And the consultant involved in the case would be very grateful as well.
I've put in what the SSG requires in the chat. And it basically says, can you provide a second opinion if required? Show us the complexity, show us that you can safely keep confidential information confidential, show us a triangulation of what you learned in that medical report with a curriculum item, and show us that you can write good notes. That is what the SSG has said. We are still waiting for any questions that our participants have. Please just put them in the chat and we'll pick them up. But maybe we should move on to our last section for the day.
So the last section is referral letters, discussing patient handling. And James, if you want to, happy to talk about that. Or
which, so say this again, patient.
So referral letters regarding patient handling.
Yes. So this comes out commonly from endorsements of results. So every day when endorsements are done, there's often a letter that's required, usually to the patient's GP or sometimes the patient themselves, and actually getting involved in that process. This is relatively straightforward. It just takes a bit of effort, but there's lots of communications and referral letters to other for follow-up of certain cases, whether it's through I don't know, nodule clinics, that kind of thing. But there are certain referral letters that are really good to put in there as well. But I mean, it's this one shouldn't be a stressful one. It's relatively straightforward. I mean, it's when you start thinking about referrals, reports, and letters from ED, it sounds a bit odd, but actually we do loads of them. We just don't realise it. So it's just getting involved in that process.
So what did I put in this section? I put referrals that I've made to anaphylaxis clinic, to first fit clinic, to ENT clinics. If I've sent patients to be reviewed in the adult ambulatory unit, and we have a communicate function in my department, I've taken those letters that I've sent in. We have ORs at our hospital, where we refer to the neurosurgeons, and sometimes we need to give quite a lot of information there. So I printed out an ORS referral. Those are some of the examples I put in.
Thanks, Priya. I also think about this when I often will write, you know, if I've got a patient who comes in with a sort of an acute on chronic issue for which they're already being seen by another specialty team, I will often, if I discharge the patient home, I will often then send an email to their kind of specialty doctor, maybe who they last saw in clinic, and just explaining that they've been in and perhaps they need their next appointment to be brought forward to be seen sooner, that sort of thing. I imagine, Simon, is also the kind of thing you could use.
Yeah, these are all really good examples. One thing I would suggest is that what you could also think about is how you communicate with the patient as well as the specialty. Increasingly, I'm just writing to the patient and copying in the specialty I'm referring to. And you know, increasingly we're aware that we communicate amongst ourselves, but actually we tend to leave the patient out of this loop. So include the letter you send to the patient as well as letter you send to your colleague. Would be really nice, and show lots of domain 2 and 3 stuff, if not domain 1 stuff. You know, shows how you're thinking about a patient and patient focused stuff. Yeah,
that's a useful tip, Simon. I hadn't thought about that.
Can we include letters that we perhaps write to a safeguarding lead or a high intensity user lead?
Yeah, they completely covered. Yeah.
I've put the information that the SSG has in it, and some of the things in there are: tell us how you were involved in the patient's care, tell us why you thought you couldn't deal with this problem and you wanted some other specialist to give you advice. So show that you recognize your competency level and how you communicate your needs. Show that it's a complex case and why you need other people to join in to take care of this patient. There's other points there that you can demonstrate with this. There's a question.
So the question is there a minimum number for these letters and referrals?
I'm just checking the SSG because I don't know the answer to that question.
This says at least 3.
Yeah, I think that's the number. Yeah.
Personally, just to say, as a consultant, I think you need to demonstrate that you're involving, you know, the whole patient kind of experience thing, and being a bit more thoughtful about outcomes and follow up and that kind of thing. So I think my feeling would be a GP discharge letter is just not going to be as weighty as, say, you know, a follow up for someone who you know, writing to the patient about the fact that they might need a repeat investigation following a course of treatment or something like that. So that's my feeling. So I would probably steer clear from that. I'm sure it probably could be counted, but I just don't think it'd be weighted as much.
Yeah, so they certainly, people certainly do put the discharge letters in, or see Bilal's written the simple referral letters. You can put those in, but actually, what you really want is something a bit more nuggety than just a standard please refer to 2-week clinic type stuff. It's, you know, why, and demonstrating your process as to why this is complicated, because that isn't really a complicated thing. So, you know, make your three ones really good ones. You can put lots more in. There's no maximum to how much you can put in. You can put, you know, these are examples. And again, if you have a summary at the beginning, I keep saying a summary at the beginning, saying, look, I've got 3 ones that are really complicated. This is why they're complicated. I've also given you, just as a freebie, a few other referrals to show my usual standard is quite good. But actually, they're not the complicated ones. The complicated ones are my top 3. Because we can generate this simple referral GP letter fairly easily. So you can put as many as you want of those, of your good ones in, but have 3 really quite interesting, complicated ones about why they're complicated. So yeah, maybe a patient has been given the runaround, or with chronic problems that aren't really being addressed, and show that you've really thought about how you can help this patient's journey move on.
Yeah. I think there's another question about the format of the letters. Do they need to be in a professional format? I guess a lot of the work we do potentially is via email. I don't think I ever have any sort of letters as such that get sent through the post. Everything's done electronically via EPR or via email.
There are some automated PDFs that at least we have in our department, which is an automated ENT referral, where you just click and send. Does that count? I think that's the question.
I think it would count, but I would put those in the extra bits. Yeah, I would choose 3 where you've done. Now, again, it can be by email. I've seen, and that is the modern way of communicating with professionals. Between us, we, as you say, we do communicate, or we do emails to a trust address. But what I would also, as I said, the thing about communicating with the patient, so maybe that will be a professional letter rather than email generally. So yeah, I would include those as well. Just so you can, it's talking about your communication skills generically, isn't it? So the email is nicely presented, but your letter is also nicely presented and has a narrative flow and is clear and concise, and that sort of thing.
Yeah. And there's another question about whether there needs to be a reflective note to go with these referral letters to demonstrate what they show.
I would let you off reflection on this one. Okay. As I say, have a summary document as to why you've selected this and why it's complicated and what you've done about it, but it's not a reflection. It's just a description at the beginning of why you've selected these 3 cases as your sentinel ones that demonstrate you can do this well. Okay. Is how I would play that one. You have to reflect all the time. It's all right.
I think we've answered most of the questions. Please feel free to ask us more questions. We have covered all of the sections, I think, that we said we would in today's webinar. So those are sections 11 to 18. Please, could I ask everyone to go and check our website again? All of the documents that you need are there to assist you. I'm going to hand over to Helen to sort of wrap up. It's just to remind everyone why we're doing these webinars. There are 52 sections in the GMC divider pack. All of the evidence that a CESR aspirant submits first to GMC and then to the college needs to be submitted under these 52 sections. What we're trying to achieve with these 6 webinars is we've split these 52 sections into 6 webinars, and we will discuss each section in detail and have you ask us questions and have you pose us to our expert speakers your own struggles with each section, and then we can answer those. So that's what we're going to do. We'll be continuing with 4 more CESR webinars. Helen?
Thanks a lot, Priya. So our next webinar is due to be hopefully end of August. We need to set a date, and the idea is that then so August, September, October, and November. Absolutely. So what hopefully this it is going to motivate you to start putting evidence into your portfolio, and come to our next webinars with any kind of questions you've got about some of the next sections. So we've gone up to section 18. The next sections are going to be from 19 onwards for the next webinar. I want to put a big thank you to our team today. So thank you to Priya for being a wonderful co-host, to Simon Smith, James Ray, and to Tom Hughes for all of your expertise and enthusiasm for what could have been quite a dry, webinar, but actually There's a lot of stuff to get through, and hopefully you guys have found it really, really useful.
Thank you very much for joining us.
Until